okay? You're tall. Like a visa.
Good morning. And welcome. If anyone needs seats, there are more seats in the front. I want to be sure you feel like you can join us. It's just a pleasure to welcome you to our School of Nursing. And I'm Doreen Harker. I'm Dean of the School of Nursing. For those of you that I might not have met, most of you I do know. And I want to welcome you to the 24th Kelley Endowed Lectureship. What I can share with you is that Dr. Kelley, and there were some wonderful slides about Jean before we started our lecture. I hope you got to see them, and we'll have them going at the end of the lecture. But Jean has had an extraordinary and sustained impact on doctoral nursing education, graduate nursing education, both here in the state of Alabama, but across the whole southern region, and was recognized for both her national impact and her international impact in graduate education. She really pioneered graduate nursing education, was a graduate of the University of Alabama, and then NYU, and then was not a graduate of the University of Alabama initially. She graduated, got her doctorate from the University of Alabama and NYU, but came and relocated to Alabama with her husband, who was an attorney who was actually in the military, and was actually at Alabama getting his law degree. So she spent her entire career, almost, right here in the state of Alabama, between the University of Alabama and then she came to UAB. And her mark on this school is legendary. She, along with Dr. Margaret Kenny, really, pioneered the doctoral program in nursing, and that was the Doctor of Science in Nursing. It actually was initiated in 1974. And I know all of this history very intimately because a year and a half ago, we converted those Doctors of Science in Nursing graduates who had the DSN degree to our PhD degree based on rigor, the extensive rigor of science in that program. And some of the scientists that have graduated from that program are the people who have really led nursing science in this country. Cindy Dunbar, one of them, and a whole host of people. So what I can share with you is there were, between 1977 and 2005, there were more than 375 doctorates of nursing from the DSN program, which is a phenomenal number because usually you count the number of graduates annually on one hand from a doctoral program in nursing. So that gives you a sense of the impact of this program. As more evidence of the impact, and I knew about Jean before I came to Alabama, but I had never met her. But just to give you a sense of her impact, more than 20 deans in the state of Alabama in the southern states were mentored by Jean. In fact, they called them the Kelley Girls. And, I was never a Kelley girl because I didn't graduate from the school. But I have to tell you, I felt like a Kelley girl after I got here. Because I would get in the car with Jean, and we would go to different places in the state, and she'd give me all this incredible history. Just incredible about some of the things she and her faculty colleagues had done in terms of laying the foundation for graduate education. And at that time, UAB was the only place that was providing graduate nursing education. So it was just a privilege to be with her. I also had the opportunity to be with her at the SREB conferences. And, up until last year, Jean was going to every SREB conference, and folks were just, would flock because she was such a wealth of information. And again, had such a great perspective on nursing education. Not only did she mentor deans of schools of nursing, associate deans of schools of nursing, assistant deans of schools of nursing, she mentored many presidents of universities, which gives you a sense. Our own Carol Garrison was here under Jean's aegis. And even chancellors and endowed chairs. So, and lots of organizational nurse execs. So her impact really is far-reaching. I will tell you, Jean's dream was always innovating curriculum, doctoral education, and curriculum that was always on the cutting edge. And I think this school has continued to push that dream forward in graduate nursing education, and will continue to do so. Today's the first Jean Kelley Endowed lectureship that she's not here in the audience with us today. Jean actually fell and had a hip fracture, so she's in recovery with that hip fracture. But I do want you to know that Jean, is going to be watching this presentation. We are going to be video streaming it for her, so she has access to it. And Eve Ray is going to be visiting her this afternoon and, helping her watch it. So we are all focused on helping Jean get well. So I want you to all say to me, with me, Jean, let's get you better and move it around again. Okay, go. Jean, let's get better and move it around. Okay, we missed you. All right. I just think, again, Jean's impact cut across not just our school of nursing, but across many, many schools of nursing. And nothing made her happier than this week, that where we would host this lectureship. But it was not just a lectureship, it was an opportunity for our faculty, for our students, and to really celebrate doctoral nursing education, but also get together and really stimulate each other with new ideas, new seminar ideas, etc. And I have to say, Dr. Jackie Campbell, who Dr. Manassas is going to get to introduce, is a fabulous person to share this endowed lectureship with, because she gets it. Her career has been focused on the development of research scientists and faculty scholars. So she gets what mentoring means, and I think understands the significance of this endowed lectureship. So what I will share with you all is thank you all for coming. I think you're going to hear a very compelling presentation, one that we think is crucial both to the state and the southern region in terms of the populations we serve. And it's an area that continues to need nursing leadership. And you have many opportunities. So I'm going to get on with the program, and Dr. Manassas, thank you for introducing.
Thank you, Dean Harper. So good morning, everyone, and welcome to all of our students, our faculty, our staff here in the School of Nursing, as well as in the university. We also would like to say a very, very warm welcome to those of you who are also in the Birmingham community. We welcome you here today. I'm the Associate Dean for Research here at the School of Nursing, and introducing our annual Jean Kelley Lecture is always one of my distinct pleasures. And today in particular, we're very, very, very excited to welcome Dr. Jacquelyn Campbell as our 24th annual Jean Kelley Endowed Lecture. So I have the distinct honor of sharing with you a little bit about her background. She is the Anna D. Wolfe Chair and Professor in the Johns Hopkins University School of Nursing. She also has a joint appointment in the Bloomberg School of Nursing, School of Public Health. She is an international leader in advocacy and research on the effects of domestic violence or intimate partner violence on families and communities. Her extensive and productive scientific research is focused on violence against women and women's health. She has been the principal investigator on 12 major NIH, National Institute of Justice, and CDC research and community grants, and she has written more than 225 articles and 7 books on intimate partner violence. Her studies have paved the way for a growing body of interdisciplinary investigations by researchers and scientists across many disciplines, including nursing, public health, and medicine. Dr. Campbell's expertise in intimate partner violence is frequently sought by national and international advocacy and policy makers. She was a member of the congressionally appointed United States Department of Defense Task Force on Domestic Violence. Dr. Campbell was elected to the Institute of Medicine in 2000, and she was a founding co-chair of the IOM Forum on the Prevention of Global Violence, and the IOM, American Academy of Nursing, American Nurses Foundation Senior Scholar in Residence. She also co-chaired the steering committee for the WHO multi-country study on violence against women, and she also served on the board of directors for a number of different shelters, including Futures Without Violence, and has also served on the board for the House of Ruth Battered Women's Shelter. As a nurse educator and mentor, Dr. Campbell leads by example. She has inspired not only our current generation, but past as well as future generations of nurse scientists and researchers across the United States, as well as at Johns Hopkins University School of Nursing. She has taught at the undergraduate, the graduate, and the doctoral level, and she is also the PI of the T32 program for pre- and postdoctoral fellows focusing on violence prevention research. She also serves as the National Program Director of the Robert Wood Johnson Foundation Nurse Faculty Scholars Program. During her illustrious career, Dr. Campbell received numerous prestigious honors, including the Lifetime Achievement Award from the U.S. Department of Justice Family Justice Centers. She was also named by the CDC as one of the 20 national leaders, as well as visionaries who have transformed and has had major impact in the field of violence and injury prevention. Meanwhile, other honors also include the Pathfinder's Distinguished Researcher of the Year by the Friends of the National Institute of Nursing Research, the Outstanding Alumna and Distinguished Contributor to Nursing Science Award from Duke University School of Nursing, and the American Society of Criminology Vollmer Award. So without further ado, please join me in a very hearty UAB welcome to Dr. Jackie Campbell.
Well, that was quite an introduction. I am very honored to be here. Jean Kelley sounds like she is an amazing woman, and I join all of you with telling her to get well, and get up and out, and get back to doing what she apparently does incredibly well, which is to support the University of Alabama, Birmingham School of Nursing. I also am very honored to be one of that list of other nursing leaders who has given this lectureship. It's a very awesome list. If you look on the back, I'm like, whoa, I'm in good company here. So I thank you very much for the invitation, and I am absolutely delighted to be here. Do my thing and get it up. You know, we, like everybody else, are into branding now, so, you know, when you speak abroad, you have to use the Hopkins stuff. So, you know, take that with a grain of salt. And one of the things that I did between putting the title that is in your program versus the title that you see here and on the slide printout is I changed it a little bit to a community response, not just a healthcare response, because in the meantime, you might have heard that we have what we like to call in Baltimore a bit of trouble a bit of unrest. We do not like the word riot because if you've been through riots, we didn't have riots in Baltimore. We had some trouble, but we also had the national media replaying the same footage of the couple of hours that were the worst, again and again, as if it was in real time, and as if it was happening over and over again all over the city. And what I was telling people yesterday, you know, the big fire, and I don't know if you saw it on the cover of the New York Times next morning, you know, Baltimore burning, was actually a construction fire that was accidentally set. It was on the other side of the city from where things were problematic, and that the only reason it got huge was because the fire department, rightfully so, was concerned about going out to a fire without a good police protection that particular night in Baltimore. So they had to wait until there was some police available on the other side of town to come over to be sure that they were safe in putting it out. So it got way out of control. It had nothing, it was not intentionally set. There was no arson in that fire. And so, you know, it makes you realize in terms of our media interpretation of local events. And I would say when we think about the community response, and I'll make some of these points as we go along, you know, that Birmingham also may have its moment, because I know this city is not without its tensions. And that, so one of the things that you need to be aware of is what is happening in our communities at large, not just how we're responding to it in the healthcare system in terms of the effects of trauma and violence. So before I go any further, I want to introduce you to my grandchildren. First of all, aren't they cute? And secondly, one of the things that beautiful young lady up at the top, I do have a laser, is my daughter Christy, who's a pediatric nurse practitioner, of which I am very proud, needless to say. Her handsome husband Nick had to pass all kinds of domestic violence tests before he was allowed to. My wonderful son Brad, his beautiful wife Nadia. Brad's complaint when he was growing up was not only was he responsible for never being violent toward a woman himself, he was also responsible for none of his friends ever being violent toward a woman. When he got to college, it was his classmates that, you know, writ large, that he was responsible for. And now that he's in the corporate world, he's responsible for none of his coworkers being violent toward a woman, and that one of their charities has to be a domestic violence advocate. So he's a good kid. But he also, he called me a couple of years ago now, when this one, Layla, the youngest of the bunch, 7.5, Grandma, when she was 4, and she was old enough to get into all of Nathan's toys. And not only did she get into all of his stuff, but she also had turned into a champion fighter. So when he tried to remove her from his stuff, he got bitten. So Brad is like, so Mom, I know the big principles. We're raising these children to be nonviolent, but exactly how on a day-to-day basis do I intervene with these two so that Nathan doesn't wipe her off the face of the earth? So we talked about that, but as we were talking about it, I was saying to him that, and as we were talking about some day-to-day interventions that they might do and brainstorming around that, I'm thinking, who is teaching the parents in our community to raise their children to be nonviolent, especially if their home was a home that people used hitting to resolve conflict? How are they supposed to know to raise their children to be nonviolent? And that's one of the things as a community I think we need to think about, is how are we helping parents and how are we helping our young people to be nonviolent. And one of the ways as a community that I would commend to you, and as was said, I'm on the board of Futures Without Violence, a very proud member of that board. It's a national organization. The website is up there. They have all kinds of materials you can download. They have materials, they have posters you can put in clinic settings around the intimate partner violence and various forms of partner violence, reproductive coercion, great for family planning clinics. But they also have, amongst many other materials, they're all free, you can download all of them for free. They have this campaign which is called Coaching Boys into Men. And it has been tested with evidence that it's been published in the American Journal of Preventive Medicine, that using this campaign has been effective in decreasing repeat violence by young men in communities. And what it is, it's a coach's playbook that it's a little trifold, and as I said, it can be downloaded for free, that gives coaches of any kind of team, and there's one for every team you can think about, gives coaches some lessons of nonviolence they can teach the young people on their team, as well as how to hit the ball, how to kick the ball. And one of the things that, going back to these kids, this one, the oldest, Grace, is a very good soccer player. And her father, Nick, is one of the coaches of her team. And she is very fast, and I'm watching a game one day, and she goes from one side of the field to the other and absolutely wipes out this young lady on the other side of the field, gets the ball, goes down and scores. You know, hurrah, she's the heroine of the game. And so I said to her father afterwards, was that legal? I don't know anything about soccer, but you know, that looks, you know, kind of, ooh. And I noticed the rest of the game, that little lady is like totally intimidated, looking to see if somebody's going to come out of the blue and wipe her out. And I'm thinking, so what did Grace learn? Be super aggressive, take the ball away from somebody and hurt them in the meantime, and you get all the accolades for scoring a goal, and you also intimidate that other young lady for the rest of the game. And so Nick, her dad says, well, you know, we try not to call too many fouls. We try and let them play, you know, kind of thing. And I'm like, yeah. So I, of course, download one of these coaches' playbooks. So Nick, what have I got a deal for you? And he's like, you expect a lot out of me, don't you, Mom? I said, you better believe it, darling. And so he looked at this, and he said, well, you know, this isn't bad. You know, maybe this is a good idea. These, you know, 5 simple lessons that we could teach along with, you know, ball handling skills. And so I said, well, let me download several hundred for you. So he took them to the coaches' meetings, and they all have adopted it. And this is something that we can do on the community side, on the prevention side, that's fairly easy to adapt. And the Futures Without Violence can help if any of you are involved with any coaches or any teams. Futures Without Violence will help you get it implemented in this community. And it's a small step, and there's many things like that there. Okay, so one of the things in terms of, I'm all about research informing policy and practice. And so I believe that our practice has to be grounded in effective interventions. And so something like Coaching Boys into Men that has been tested and has been shown to be effective is the kind of practice things that we need to do. Translational research for the whole way on the continuum is something that we really need to think about when we're doing research on violence and trauma or whatever kind of research we're doing, so we can make a difference in our communities. And the notion of holism, which is an old premise in nursing, but that biobehavioral, physiological mechanisms that affect health, we need to understand and we need to work together, interdisciplinary, to get those kinds of information in our research. We also have to make sure that there's cultural appropriateness, cultural safety with those interventions so that they work in different communities with their different contexts. The interdisciplinarity is incredibly important and something that builds on strengths. So one of the things in Baltimore that everybody was pointing out, all the bad things about Baltimore, all the over-incarceration, all of our school problems, all of this problem, all of that problem, our community also has strengths. And we need to build on those strengths. We need to, one of the things in our community, we have a really strong faith culture, a really strong church culture. So we need to get those churches involved with violence prevention. We need to get them involved in those endeavors. So building on strengths is incredibly important of communities as well as on the strengths of individuals. So rather than just, saying, well, you grew up in a violent household, you got this wrong with you and this wrong with you and trauma and PTSD and blah, 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 blah. What is that individual's strengths that they bring to this in terms of being able to deal with it? And importantly, the addressing health inequities. How do we diminish health inequities? It's not enough to research the connections. It's time now to start ending some of those health inequities. And not only health inequities, but also justice inequities. And then collaborative with advocacy organizations. Is there anybody here from a domestic violence advocacy organization? Thank you for coming. And a very important collaborator in terms of working with communities and working with abused women. And also the organizations of marginalized populations, incredibly important to work with to address these issues. Because, for instance, someone who's an immigrant from another country is unlikely to tell a healthcare provider, yes, I'm an abused woman, because of fears in terms of documentation and because their abuser may be threatening. If they're not going to get deported, somebody in the family, they're going to report them to INS. But they are likely to seek help in an organization that is set up particularly for those cultural needs, for those cultural services. So we need to work with them to provide that kind of help. So we all want justice, and this is, from this Baltimore thing. And in order to make progress on violence against women and children, we all want justice and we all want nonviolence. And so we have to pay attention to the violence and injustice in our communities, as well as the individual who's coming to the healthcare system or is coming to a social service organization with the problem. We have to think larger. We've got to collaborate across sectors, and we must remember that every violent youth, each one, if you saw the pictures of our youth in Baltimore, heaving rocks and pieces of concrete at the police, every single one of them, male and female, was a child once. We all care about the children in our community. And many of those children were probably ones who grew up in a violent home or in a violent neighborhood. And they were impacted by that. And that whole notion of growing up in a toxic stress kind of environment not only affects the body, affects your health, but it also affects your ability to learn. And so you oftentimes have this cycle where these are the same kids that are having trouble in school. And in order to address this, even if we, like me, are primarily concerned with violence against women and children, we have to engage boys and men in this endeavor. We have to keep them thinking about them in the forefront, and we have to have programs that engage boys and men. So again, Futures Without Violence has a terrific campaign. They have a National Institute on Fatherhood and Domestic Violence. One of the things in Baltimore, we have way too many of our young men involved in the criminal justice system. They're either on parole, or they're actually in jail, or they were in the juvenile correction system. And then it makes it very hard for them when they get out to ever get a job. Oftentimes they don't have a full education. So part of what we need to be doing is thinking about those prisoners, those parolees, in terms of not only job issues, and that's a big one, and educational issues, and that's a big one, but most of them are fathers. And we need to think about how they are going to father their children in terms of teaching them nonviolence. You know, how do we get those fathers to think about raising their children nonviolently the way my son was taught, of course, that way, but to think about that when he's raising his children. And it shouldn't just be me. So this National Institute on Fatherhood and Domestic Violence is at Futures Without Violence. Oliver Williams is a wonderful, he's the director of the domestic violence in the African American community, and is available for consultation with these kinds of programs in terms of prisoner reentry programs that address the violence and that are trauma-informed, recognizing that these men have had a history of trauma, likely in their own lives. And one of the places where we get this knowledge about how childhood trauma affects people is through the ACEs study. You can go to the CDC website. There's been hundreds of articles written on the original ACEs study, as well as the ACEs junior studies with other populations. One of the things to keep in mind with the original ACEs study is that it was done in San Diego with primarily white employed Kaiser Health System members, well-educated group. So the findings from the original ACEs study is not an inner city population, although it has been replicated with other populations. So what they have found is with adverse childhood experiences, you're more likely to have social, emotional, and cognitive impairment. There's more adoption of high-risk behaviors like smoking, for instance, and there's more disease, disability, and social problems, and importantly, early death. The more ACEs, the more adverse childhood events, the more likely these people were to die early, primarily from cardiovascular disease. So, a direct connection and very compelling evidence. And I'll tell you a little bit about it. So the adverse childhood experiences, the original ACEs study looked at childhood abuse and neglect, growing up witnessing domestic violence in your home. And we did a dating violence study in Baltimore where we found out that the most predictive factor with kids in middle school age being violent in their relationships was growing up in a home where adults hit each other, primarily parents, in order to resolve conflicts. And that was more predictive than the community violence they had experienced, but that's also something that these kids oftentimes see. That was more predictive than them even being abused as a child. So that witnessing domestic violence is a very powerful adverse childhood experience. Also, abuse or substance abuse or mental illness in the home. So if you have a parent who's a substance abuser, and of course we know that the more you are victimized by violence, the more likely you are to use substances. And that substances do not cause you to be violent, but they certainly exacerbate that whole situation. And so you oftentimes, again, have a traumatic childhood. You use substances in part to cope with that, to make all those symptoms of PTSD, the re-experiencing the trauma, the hypervigilance, to try and tamp them down a little bit. And then it oftentimes becomes a problem using those substances, which exacerbates your possibility of using violence. And parental discord or a parent being incarcerated. So we think about Baltimore City. So many of these kids have that parent incarcerated as one of the adverse childhood events. And some other research has widened that out to witnessing community violence. We have something in Baltimore City, we had more than 70% of our middle school age kids saying they had seen someone either shot in their community or beaten up so badly that an ambulance had to be called. So major violence that they had witnessed in their community, as well as oftentimes at home. We also find Teresa Brockie, this was just published in the American Journal of Community Psychology. She's an enrolled tribal member of one of the Clay Mountain tribes in the Plains. And she found that historical trauma was also an important aspect of adverse childhood events for our Native American, our indigenous populations, who have incredible rates of family violence, as is true of every indigenous population in the Anglo world. So we see this in Canada, we see this in Australia, we see this in New Zealand, where all of those indigenous groups have high rates of family violence. And so what is that about, in part, is that all of our countries in the 1920s through the 1960s, we decided the way to make sure that our Native American population got acculturated, adopted our cultures, was to take all the kids and put them in boarding schools, take them away from their families, not voluntarily, involuntarily, put them in a boarding school and keep them there 12 months out of the year. No summer vacations because they might go home and get, back into the old ways. And those boarding schools in all those 4 countries beat the language out of people. The children, if they used their native language, they were beaten. Beat their language out of them, beat their culture out of them, and after 12 years sent them back to their homes on reserve or wherever they came from, and wondered why, when they had their own children, they didn't know how to parent. Wondered why it was that many of those who had experienced that boarding school situation turned to substances, had problems with drinking, and attributed that to a cultural or genetic issue versus looking at what had happened to so many of those kids. And then, big surprise, a lot of them abused their own children because they didn't know how to parent. And then, so we used the foster care system, protective services, to take many of those children away and put them in foster care. And so this kind of experience, this intergenerational transmission of trauma, Teresa has found is significantly associated with the high rates of suicidality amongst our Native American youth. And so, that's one of the things to think about in terms of both a global reach around some of these issues and also what kind of historical trauma people have experienced, as well as community violence. So, adverse childhood experiences are common. And remember, this is a well-educated, middle-class, mostly white population, where they had seen this much of 28% of the, and they were adults when they were asked about this, were physically abused as children. that emotional and physical neglect also happens, as well as witnessing domestic violence. And they're not only common, but they go together. So we find that when one actually sees one's mother abused, they are very likely to have also been abused themselves. So the child abuse goes along with the witnessing domestic violence. And we get, with the frequency of witnessing domestic violence, the kids that were physically abused, close to 90% of them witnessed domestic violence frequently. And when we talk to abused women, it's incredibly important that they understand the effect this has on their kids. And it's incredibly important that they realize that the kids know, even if they weren't in the room. One of my colleagues, Janice Humphreys, did a wonderful study where she actually interviewed the children of abused moms. And those abused moms all said, oh no, my child never actually witnessed us hitting each other or him hitting me. And this little girl said, I used to lay awake at night. I do, lay awake at night. And I'm waiting to hear if mommy and daddy are going to fight. And if they do start fighting, then I have a couple of different things I sometimes do. Sometimes I wet the bed so that, and this is something she gets punished for, so that they have to come in and change the sheets. Sometimes I pretend to fall out of bed, thump, and then start crying. This is a 6-year-old girl whose mother thinks that she has never witnessed domestic violence. And so one of the most powerful interventions we find is helping abused women ask their children if they're worried at all about what's happening between mom and dad. And admitting to the child, things are not perfect between us. Whatever words they want to put on it, but hearing from the child that the child is scared or that the child is affected. And that's the most powerful intervention. And it's not necessarily that she has to leave, but that she needs to do something about the abusive relationship. So they tend to come in groups. You had a battered mother. You are, 95% likely to have at least one other adverse childhood event. And more than half of these adults who had witnessed domestic violence or been in the room where there was domestic violence had more than five or more adverse childhood events. And so when they looked at the prevalence, they found that 16% of this group had 4 or more adverse childhood events. Again, white, middle class, well-educated crowd of people. And that only 33, only a third, had none. And so these are very common. And so we see that the more ACEs, the higher ACE score you have, the more likely you are to smoke. And we oftentimes find this with abused women, is abused women are twice as likely to smoke as non-abused women. And so that's part of that cascade of health problems, obviously, and they find it very difficult to quit. So what is that about? What's happening in their body? That stress response that's been overactivated. And what they found is that although nicotine does not calm you down, the deep breathing you do with smoking is the relaxation piece of it. And so what do we do when somebody is having trouble quitting smoking? We give them a nicotine patch, and that's supposed to fix you. And so what is that doing for the relaxation response? Nothing. So, it's in terms of tailoring our health advice to the kinds of trauma that people have experienced. And we're calling that now trauma-informed care. And the SAMHSA website has a whole host of things that have been shown to be the kinds of interventions for the trauma piece that can be helpful in terms of bringing down some of these symptoms that go along with trauma. So you have early smoking initiation with the more ACEs, COPD when they grow up, and yeah, that really makes sense, doesn't it? But how often do we ask what happened to you in your childhood that might be contributing to this health problem? And not that we can take it away, but we know how to do some things to make the effects of that trauma less. HIV risk. How many of you are working in HIV prevention or treatment? All right. So important that we know what's happening to HIV positive people or what has happened in terms of trauma. We find that women who are abused, who are HIV positive, and by the way, we have unconscionable rates of death in this country for HIV positive people. And although, I was telling the doctoral students yesterday, my kids all say, Mom, you see violence everywhere. I'm like, yeah, but, it does have to do with things, because we find that abused women who are HIV positive are less adherent to care. They're more likely to be depressed, which makes it more difficult for them to deal with all of the symptoms, etc. And we also find that oftentimes multitude of adverse childhood events plus the domestic violence and additional trauma is affecting their immune system and is affecting the effectiveness of the ARV treatment. So it's important that we find, and we also know that some of the deaths in HIV-positive women are due to suicide, because we know that a history of ACEs as well as adult domestic violence is very much a risk factor for suicide amongst women. And we also find that some of them die from homicide, and it's partner homicide more often than anything else. And so those mortality kinds of case conferences that we do in our HIV populations, we have to think about the homicides and suicides as well as some of the other issues. The other thing is we find that, what's our prevention for women in terms of HIV? We say you have to make sure he wears a condom. And here we'll give you a banana and you can practice putting it on. And how many of those women are just rolling their eyes and say, with a guy who hits me, I'm supposed to make him wear a condom? Are you kidding me? And 40 to 45% of women who are physically abused are also being forced into sex by their partner. And they're also more likely to have STDs, which makes it more likely for them to contract HIV. So we have a multitude of issues that are coming together with this in terms of being more likely to have an STD. And this is from the adverse childhood events, never mind the domestic violence. Prevalence of severe obesity. We find this trauma affects the entire physiology. It affects the immune system. It makes you more likely to have an inflammatory response. We know that inflammatory response is related to being overweight. Your BMI is affected by that. And yet, when we do weight loss counseling, do we ever take into account that trauma history? Do we ever ask about that? And so that's important also. Prevalence of liver disease, hepatitis, jaundice. So what's that about? Probably overuse of alcohol, right? Attempted suicide. When we have close to 20% of this original ACEs population, if they have 4 or more ACEs, having actually attempted suicide. Lifetime history of depression, much more for women than for men, but still, and again, it's not all of the explanation for the increased prevalence of depression in women, but it's part of it. And if we only treat that depression with antidepressants, we are inadequately treating that depression because the history of trauma has something to do with it. Rates of antidepressant prescriptions, and all these are available on the CDC website. And then unintended pregnancies or elective abortions, also much more associated with 4 or more ACEs. So we have this cycle, and what they found, especially for women who had had 5 or more ACEs, they were very likely to be in an abusive relationship as an adult. Now, were they going around looking for an abusive man like their father was? No, they were not. Did they sometimes think when their partner hit them that that's what happens to women? It happened to my mother. It happened to a lot of the people in the neighborhood. And oftentimes they will tell me, and he's not nearly as bad as, you know, somebody, my sister's boyfriend. And they're often likely to get stuck in that relationship because the PTSD that they had as a child from these ACEs kicks in again big time. It's very paralyzing. And for women, they're usually comorbid with depression and PTSD kinds of symptoms. And it's really hard to get up in the morning, let alone figure out how to get out of an abusive relationship or manage to make the violence end. It's always amazing to me that more than half of women in this country do either leave an abusive relationship or manage to make the violence end. But it takes a while for that to happen. And so meanwhile, we have to take care of their health if we're in the healthcare system. So this is just one of the pictures from the ACEs website. It's a strong relationship with all of these issues and increasing the risk of all of these diseases and other risks for the leading causes of death. And importantly, as I mentioned, that decreases learning ability. This whole notion of toxic stress. You know, they've done imaging of kids' brains that have been exposed to violence as children, either child sexual abuse and or physical abuse or witnessing domestic violence. It's really frightening in terms of that the brain is not developing normally, and that we have effects both in the hippocampus, which is our emotional center, et cetera, and in the cortex. So it makes, and I talked to a veteran of the Afghanistan war who explained to me more better than anybody else ever had, or all those pictures of brains. He's like, when I came back from Afghanistan, and I had clearly PTSD, but I didn't want to tell anybody I had PTSD because I didn't want to get stigmatized. I didn't want my career to be affected. I didn't want to have to go through a bunch of stuff with the VA, you know. So I was trying to deal with it myself. So I would walk down the street, and that hyper-arousal that goes with PTSD, he's like, I am loaded for bear. I'm just like, I dare anybody to say anything to me. And he said, it's a good thing I didn't have a girlfriend, because I am sure if I had a girlfriend, I would have ended up hitting her. So what I would do, and he was a sniper, and the biggest thing with PTSD for people in the military, I don't know if you've seen that wonderful movie. Okay, so the biggest risk factor for PTSD is killing someone. Far stronger than having, however horrible it is, a buddy get blown up or something like that. Far stronger, killing. And he said, I would be walking down the street and I would see somebody's head like a bullet blew it up. And that was my, flashbacks. That was my re-experience of trauma. And you know what I would do? I would go into a bar and I would drink because I would hope that would, tamp things down. And then I was like, oh, I just dare anybody to say anything to me. And I got arrested for assaults, for bar fights, 3 times within a month. Unfortunately, he was sent to Veterans Court. You all have a Veterans Court here. I'm sure you must, because you have a big veterans population, where they understood some of what was going on with him. And so rather than going to jail, he was diverted to a PTSD treatment program. And we find that the connection with family violence is our veterans that come back with PTSD, they have PTSD, they're twice as likely to hit their partners, to be violent toward their partners. So that hyperarousal, that hypervigilance really kicks in for people that have PTSD. And those youth in Baltimore, heaving rocks, you know, they were like, oh, give me a good excuse, you know, and that kicks in. And if the cortex has been affected by this toxic stress, the thinking part is not saying, oh, let's weigh the consequences, yeah. That's not going on. And yet, what we did with a lot of those kids is we put them right to juvenile justice. And they are now caught up in the juvenile justice system. And I'm not sure it's very trauma-informed, at least not yet in Baltimore. So one of the things, we've made some progress. Baltimore has calmed down. We've got some things in place. The DOJ is involved. You know, we're going to have a consent decree like they do in Cleveland. So but we will do things differently in our cities. We're starting to think about this, I think. This interdisciplinary response across sectors is incredibly important. We have to decrease homicide. In the last month, since Baltimore calmed down, unfortunately, we've had more homicides in the city than in any one month in 20-some years. So we're like, oh my goodness, what's this about? And of course, the last thing I read is they're blaming it on drugs, which, you know, I'm sure that drugs, you know, there was a lot of drug stealing, some of the pharmacies, and now that's disrupted the drug trade. And I'm like, you know, all of it? I don't think so. The last one was an intimate partner homicide where a child was also killed. I don't think the drugs had anything to do with that. So we must decrease the incarceration rates and increase employment opportunities and education in our cities. If we're going to address gender-based violence, we have to take care of our communities. And we have, indeed, decreased domestic violence homicides in this country since 1976. And this is something to be very proud of. And our domestic violence advocacy organization, the laws that we have in terms of domestic violence have had a lot to do with that. And we've made progress in attention to domestic violence in the healthcare system. This report in 2011 resulted in a provision in the Affordable Health Care Act that now, at well-woman visits, there is insurance coverage for screening and brief counseling for domestic violence. So how many of you women in the audience have been for your well-woman visit? All right. How many of you were asked about domestic violence? All right. Now, next time that happens, be sure your provider knows that you think it was a good idea they asked, because they're probably not sure. This is something they were told to do, and they're like, okay, all right, so be sure. And if you weren't asked, you ask your provider, how come you didn't ask me about domestic violence? I happen to know. That's in the Affordable Health Care Act, and you were supposed to be asking. And so how many of you were asked well? Some of you. Excellent. So that's the other thing, is, you know, this part of the Affordable Care, it can't force providers to ask well, right? So sometimes they ask very badly, like, you weren't abused, were you? You know, so that's one of the things that we have to do in terms of teaching our students, our nursing students, our medical students, how to ask well. They're going to be expected to do this now. And it's also being rolled out in the VA. It needs to be in our emergency departments better. and mental health, and also chronic care settings like chronic pain. We have a whole lot more chronic pain amongst abused women. So we need to be asking in other settings as well as the well woman visit. And you have these slides, so if you want to get all the details, we have good evidence that there's screening tools that are accurate. One of the things that the people that do the ACEs work are saying those screening tools for domestic violence also have to include something about lifetime trauma. We can't just concentrate on immediate abuse, but also because all of those effects on health. So that's something that people are working on. We found some interventions to be effective, not very many. Part of the issue is many of the RCTs, the clinical trials, don't go long enough because it takes a while for the violence to decrease. You know, just because a provider asked her about violence and gave her what we call a warm referral, which is making a referral with her versus saying, here, call this number or go to this website, that before she can figure out how to take advantage of those resources, those community organizations, you know, what she wants to do, what would make sense for him, is there an offender intervention program that he can get into, which is oftentimes what women want first, to try and help him, fix him, so that he can still be the father to her children, so that he can still be the love of her life, the reason she got hooked up with him in the first place. So she wants him to stop hitting her. She doesn't necessarily want to leave the relationship. So these interventions usually take a while to work, and sometimes we don't have the long-term evidence or the long-term follow-up on those. Screening alone without an intervention is not better than usual care. Just to ask somebody if they're abused and give them a number to call is not any better than usual care because, you know, those interventions are around. So it's up to the provider to provide that brief counseling. And part of that, as I said, is a warm referral. We also have women being very concerned that they're going to get reported to Child Protective Services if they say they're abused, especially if they're pregnant. So there's some of those concerns that you have to think about in terms of your routine inquiry, depending on the setting you are at. And often one of the things we found in a study we did a while ago is that women say, it would be very helpful if my provider offered to call the police. Now, I may not think it's a good idea. I may not want him arrested at this point. But if the provider said, you know, I can call the police for you, they can come and give you the options in terms of protective orders, et cetera, and so forth, and what you would want to do, and what would happen if you did call 911 sometime. But I can do it, so you don't have to say, you know, I called the police. I can take that onus of responsibility. But don't call the police whether or not I want you to, unless there's been a felony assault that you have an injury for, and then you're mandated. But otherwise, women say, give me the choice on the police call and how to involve the police and if to involve the police. What we're trying to do by screening in the healthcare system is to give women the opportunity to disclose to us and hopefully to get help early before it's so entrenched that she feels like she has to call the police. So if we're getting her help early, she may not yet be ready to go to the police. The National Domestic Violence Hotline is a great referral source you can call with her. One of the things I oftentimes do is I say, you know, we need to make a phone call, especially if it's a high risk for homicide. And either I can dial and you can talk, or you can dial and I can talk, or I'll put it on speaker and we can both talk. But rather than telling you to go do this, especially on a cell phone plan that he sees all the phones, all the calls you make, and even if it's a blocked number, he says, so who did you talk to on Tuesday afternoon for a half hour with a blocked number? So, you know, I help her with the phone there. And there's also some online services, and there's also an adolescent a domestic violence national hotline you can call. So we have to do system change. It can't be just one provider starting to ask. It has to be a whole system of supports for it, with training for the providers, the electronic health record, electronic medical record is an opportunity to have pop-up screens. But I don't know about you, the last time I went to see my provider, all he did was look at the screen and not me. So, yeah, those are useful, and there can be pop-up resources, et cetera, that are part of the electronic medical record. But we have to teach providers how to use it effectively. And there was a special issue of the Journal of Women's Health in 2014 that has a really good article on using electronic medical records and how they've done it in Kaiser. So what should brief counseling look like? We're not quite entirely sure about that. That piece has not been well tested. It has to be context and community specific. It has to be a collaboration with our domestic violence advocacy organization. They have to know what we're doing and how we're doing it, and that they may get local hotline calls from you. The case needs to be built on the need to combine attention to safety as well as her health. So we have, as I mentioned, the SAMHSA website in terms of trauma interventions for lifetime trauma, and there are some examples that do have some evidence behind them, and part of the issue is, of course, having the trained providers to provide those interventions. There was a wonderful article, Judy Bass, in the New England, no, Lancet, I believe, where she has taught community workers to do a CBT intervention for PTSD that was effective in the Congo, the Democratic Republic of the Congo, where they have like 2 psychiatrists for the whole country and maybe 4 psychologists. So it ain't going to happen that everybody that's been traumatized by rape or other trauma in the Congo from war is going to have their own individual therapist. So she's like, this is a cost-effective, this is a way that we can bring these kinds, and we still have the same problems in terms of mental health care, especially, and I know Alabama didn't do Medicaid expansion. There's a little bit with Medicaid, a little bit more mental health care available with the Medicaid expansion, but even with that, there's not enough to really do these comprehensive trauma treatments for PTSD. So we need to train community workers to provide some of this, and this could make really good sense for people that are a little bit suspicious of the formal healthcare system, because those community workers could be in other kinds of settings. There's also a few interventions that have been tested and are available for kids who have witnessed domestic violence or have PTSD from other kinds of trauma. One of the things I'm involved with, Nancy Glass, who's at Hopkins, has done an online decision aid where abused women can go online and be helped to make decisions, as we have decision aids for cancer care, for other kinds of healthcare issues. And this is something, again, one of the issues we have in Baltimore City is if you don't have a computer at home, that you can go to the library and you get 30 minutes when you wait in line at the computer before you have to leave it. So that's not very long to work through a decision aid in terms of safety strategies, et cetera, plus whatever else you need to do. We have some good baseline results. This is something that could be tested in other healthcare settings. We could actually provide, we in our ED, we call them COWs, computers on wheels, that could be provided to patients while they're, in back, waiting for whatever, to go on to this decision aid and work through this. And it's based in part on the danger assessment, which is the risk for homicide instrument that I've developed with colleagues, so that she knows, she's informed about how much risk of homicide there is as she goes through in terms of testing, of deciding on some safety strategies. There's also iHeal in Canada, which has been developed by a bunch of nurses for women in the healthcare system after they've gotten out of this abusive relationship and still had some of these health effects. So that's an important thing, and hopefully once they get it tested there, we're going to bring it down here. The Sisters of the Sister intervention, Loretta Sweet Jamat's for HIV prevention. We're testing a combination of that with the Dove intervention, which is a short domestic violence intervention for women at high risk for HIV. So they're both learning not just how to get him to wear a condom, but how to get an abusive man to wear a condom, which is easier said than done. But there are some things that we've adopted, as well as the Dove intervention for safety strategies. And the Dove intervention can go into any home visitation program. Carol Warshaw has done a really good intervention, and the Nurse Family Partnership, the David Olds home visitation program, they are developing their own domestic violence intervention that's being tested there. So there's some things happening. Now this is what they call a very busy slide, right? So the notion is that women who are abused, that we need to look at any trauma response to mental health problems that she's having. Is there injury? And this is sometimes old injury that was never appropriately diagnosed. It can be multiple. For instance, I'll say I had this woman that said, oh, it's not that bad. Yeah, we fight sometimes, and but it's not that often. It's not that bad. And you know, sometimes he does slam me against the kitchen cabinets. So part of the danger assessment is to use a calendar and look back. And I said, so you know, how long is this? You know, how many times is this happening? Well, she's getting slammed up against the kitchen cabinets like twice a month for the past year. And she has some real bad problems with neck and back pain, you know? And you're like, well, this makes sense. But does her healthcare provider know anything about the domestic violence? And she's getting pain medications, but, you know, it's not totally effective because she keeps getting re-injured. You know, and pretty soon she's going to be seen as a med seeker, you know, et cetera. So we need to look at that old injury. We need to look at what's happened in the childhood in terms of trauma. We need to look at those physiological mechanisms of toxic stress, the immune system effects. Do we have some problems there? Is that what underlying some of the physical health problems? So that our interventions need to be trauma informed. So we're not only doing whatever the health giving a treatment for the health problem itself, we're also looking at that underlying trauma. And at the same time, if she's in a current abusive relationship, we need to be dealing with the safety issues. So we need to do both the health and the safety issues, so that we increase her safety, we also decrease stress, and we increase her quality of life, and we do have improved mental and physical health outcomes. So that's the kind of thing we need to be looking for. This Journal of Women's Health also has several different articles in terms of a research agenda, some of these kinds of issues. There's also an article that Jamila Stockman wrote with myself around the particular health issues for marginalized populations in terms of how this contributes to various health inequities, like unintended pregnancy, like low birth weight infants, etc. So, and of course, there's an app for that. There's not an app for everything these days. And this is the Danger Assessment app. If you go to joinonelove.org, this is Yardley Love's mother started this foundation. I don't know if you remember Yardley Love, but she was the UVA student who was killed by her boyfriend. Mm-hmm. And she was a lacrosse player, and so was he. They were both, you know, model team players, good students, white, middle class, in fact, very privileged kids, both of them. And so Sharon started the Join One Love, and there's also a good video in terms of using for college-age populations or about to go to college in terms of a bystander intervention for domestic violence. And it's a really compelling video. And you can also download these two apps. This is the Danger Assessment Lite, which is just the danger assessment, those risk factors for homicide. And it has this cool graphic so that she sees where she is compared to other abused women. So it's very compelling to actually see this graphically, and we've tested it. And then the better one is Nancy Glasser's My Plan app, which is this safety kind of planning with an app. And you know, everybody's got a smartphone or a phone that they can put apps on, even if they don't have that computer at home, right? And so you can go through this as a friend or a family member of a young woman you're worried about, as well as the young woman can do it themselves. It's password protected. There's a lot of verbiage around keeping it safe from your boyfriend. I had one young lady tell me, well, the day I downloaded it, I downloaded 47 other apps. So I figured it would take him a long time to get through them all. And he does monitor my phone, but, I thought that would keep him even busier than, he usually is. But there's also some stuff about password protecting your phone. And so this is based on your risk of homicide, so the danger assessment is in there. It's also based on your preferences in terms of the relationship. Do you want to leave him? Because safety planning is different if you're leaving, versus do you want to stay with him, versus you're not sure, which is oftentimes true. Not quite sure what you want to do with this. And then it also has you rate your goals in life, your priorities. Are your children your biggest priority? You don't have any children, so that's off the map. Or are your studies your biggest priority? And in terms of, so the safety planning is tailored around those kinds of preferences in your life, your goals in life, as well as the risk of homicide. And then it goes through some nice safety planning. So we like it a lot. It's being tested in a number of different populations, but meanwhile you can use it. As I mentioned, Futures Without Violence has some materials to help. I know I'm starting to go long here. So this is the danger assessment. Go to the it's dangerassessmentalloneword.org or .com. You can get materials on there. There's a danger assessment for immigrant women now, as well as a danger assessment for indigenous women. And you indulge me. All right. I did want to show you a little bit about this intervention that we're doing in collaboration with many police departments around the country, which is called the LAP, the Lethality Assessment Protocol. It was one of those collaborative kinds of endeavors where we worked with police departments and domestic violence advocacy organizations to use a short form of the danger assessment that first responders give to women who have called 911 for abuse in order to see what the risk of homicide is for them, because the important thing there is that they understand if they're at high risk for homicide. It's nice if the criminal justice system knows, but the woman is the most important thing. So this is our research team. It included Bev Pacho, who is an enrolled Cherokee Nation person. Now, I have to, this is the fancy stuff. Oh.
Has Kenneth ever used a weapon against you or threatened you with a weapon? Threatened, so yes. Has Kenneth threatened to kill you or your children? You? So yes. Do you think that Kenneth might try to kill you? You do. Okay. Does Kenneth have a gun or can he easily get one? He can easily get one, so yes. Has Kenneth ever tried to choke you? He has?
He's made me put the baby down so he can hit on me. He strangled me till I passed out. It's been terrorizing. Not able to sleep. My kids have bad dreams, and I hate to see that. I hate to see that.
I'm not very old, I'm only 25. I've been in relationships, but I've come into contact with couples that have been together some longer than I've even been alive, and they come into contact with a situation that they've never had to deal with before, and they don't know how to handle it. And they don't know who else to turn to, so they call the only person they know to call for help, which is to call 911. Has Shane ever threatened to kill you or your children? Do you think that Shane might try to kill you?
He said he was going to kill me. He says it every time, but I just thought it was an empty threat. And tonight it made me believe that he would.
So first of all, I'm going to call in an officer. She's wonderful. This is CBS News footage, by the way. This is what the LAP looks like. The main thing is the protocol. Once this woman was screened in at high risk on the LAP, the next step is she calls the domestic violence local organization hotline. The officer calls and offers the phone to the woman. She does not have to ever talk to that hotline operator, but we found that more than half of the women did talk, make that contact. It was something like 70% of the women made at least that voice-to-voice contact with a care provider, and that a lot of them went to that domestic violence advocacy organization afterwards, more than ordinarily would. So the police officer can also transport her and the children. So of course we did research. I'm a researcher. I can't help it. We were funded by NIJ to do this. The details again are on your part. It was a diverse population, and we found that we got equally good results in all of the different groups. The relationship characteristics. Importantly, the strangle or choke language is in there, which has its own health consequences that are, as well as being high risk for homicide. And the main findings were that in even controlling for these differences in some of the other variables, we found that women who got the LAP, and it was quasi-experimental, so for a couple of years we did it without the LAP and then with the LAP. But even using propensity score analysis, etc., we got a significant reduction in abuse for those who actually went through the LAP. And it was primarily through going through protective actions, because the hotline operator gives her some possible protective strategies, safety strategies to use. Things like establishing a code with family and friends, obtaining something to protect yourself at follow-up. We're hoping that wasn't a gun, but engaging in other protection actions at follow-up, applying for a protective order. When we asked, did they do that? Receiving a protective order, actually more of them received medical care due to violence at follow-up, went somewhere that the partner could not find them at follow-up, and many of them actually went into shelter, and more of those partners ended up being arrested. So this is also in press, not quite in press, but it's going to be in press shortly, and this is the final scene. Jacquelyn.
Yes, this is Officer Amanda Oakland State Police Department. I have a victim here who is screening in. She answered yes to the first 3 questions on the lethality assessment. Everyone that I've given a survey to has seem to put them at ease. I know that that's what it's meant to do, is to take someone that's in an intimate relationship, kind of remove them from that cycle of domestic violence.
This is normal. It's not normal. It's not okay.
Do what?
And if I can't forgive you again, am I going to get in trouble?
You're not going to get in trouble for biting them. You have every right to defend yourself no matter what the situation is. Okay? I think it makes them take a second look at their life and their relationship. It makes them question in front of someone that's a complete stranger, being an officer, what's going on in their relationship and how their significant other is really treating them. Yes, ma'am, this officer, may I have Oakland State Police Department again? I've got another one.
The only way we're gonna live is by getting help from the police, or they're gonna kill you. That's the only way we're gonna live. Or you end up killing them.
You guys take care, okay?
All right, thank you.
No problem.
It's scary living this way. In and out of shelters. This will be the third time going to a shelter.
So the bottom line there is this was the third time she went to a shelter, and some people say, well, what's wrong with her? She has to keep going back to shelter. What's the problem? And we need to understand that this is very healthy behavior. That, you know, when we have trouble quitting smoking, and we tried 3 different interventions, we don't say, oh, that's a bad thing. When people have to go back for repeat boosters on substance abuse treatment, we don't say that's a bad thing. And sometimes it takes a while to figure out how to increase your safety. So this is one of the books that I love is Judy Atkinson's Trauma Trails. She's an Aboriginal in Australia. And she talks very much about how the trauma leaves a trail through your body and your psyche. And it's a very compelling book, and it's cheap on Amazon. And then finally, in terms of some of the health outcomes, and again, this is a busy slide, so you know you can take your time and look at some of this. But all of these, there are research-supported links. What we don't know as much about is what is the physiology, the neurobiology that really, they've been mostly epidemiological studies. So we need more research to figure out what are those mechanisms, not just because we're curious, but because that gives us intervention points that we could use better trauma-informed care to target whatever part of the physiology is and or neurobiology is being affected there. One of the other things to remember is maternal mortality, which all of our states do a review of. But oftentimes, and this is when you die during pregnancy or in the first year after delivery. And in Maryland, where we've carefully looked at this, the leading cause of maternal mortality is now homicide. Homicide. And most state maternal mortality reviews do not look at the homicides because, as the head of Maryland's review said, but that doesn't have anything to do with health. And what we found was every single one of those women who were killed, the majority were killed by partners or ex-partners, and they had been in prenatal care. We apparently didn't ask about violence in the relationship. So, you know, that's another area of mortality, and so we think about, you know, do we need to be doing PEP after rape? You know, now the CDC guidelines say we ask the woman, so was your rapist HIV positive? You know, as if you would know. And only if the rapist is HIV positive, or she was gang raped, or it was anal rape, is she even told about the possibility of PEP, the post-exposure prophylaxis. And, my contention is maybe we ought to think about at least informing women there is such a thing, even though it's not perfect. PAR is the early antiretroviral rules that they're talking about using to prevent HIV. It's expensive. It's going to be expensive. But women at high risk from an abusive partner for HIV, ought we not think about that being a strategy? That's certainly easier than making him wear a condom. Safety planning and the post-HIV diagnosis, there's another busy model in terms of how we need to think about after HIV infection with the HIV progression and how violence associates that. Where else does interdisciplinary research and practice need to go? We need to go global. And this is something that you can do for rape survivors in the Congo. My friend and colleague Nancy Glass has developed Pigs for Peace and villages where there's been a lot of rape. The women in those villages get a pig. In the Congo, if you got a cow, the heifer program, if you got a cow, that would be not acceptable for a woman. But a pig you can get, and pigs have like 7 piglets per litter, and they do it every 7 months. So you've got a lot of piglets. They give 1 piglet back to the collective. They can sell the other piglets. They use them for school fees, et cetera, and so forth. They get some respect, and you can go to that website and buy a pig. My grandchildren all get a pig every Christmas. So thank you very much, and I'm sorry to go. All right, I'd be happy to take questions, and I'm also going to be at this reception afterwards, and you can ask me things there. Yes, ma'am. All right. Great question. And there's a lot of I'm sorry, I'd be happy to. The question is for pediatric providers, what the challenges are for screening as well as intervention. And so there are many pediatric providers that are saying we ought to be asking moms, because that's where we see moms. Moms are always worried about their kids. We ought to be asking moms, are they in a violent relationship? Because we know that's bad for kids. Well, then you got the charting issue. So where are you going to put that in a chart that dad has access to, right? Question 1. So some people are putting it in a separate chart that's just, about the mom in the pediatric care provider's office and making sure that these moms get some sort of referral. There's also the ACEs community is wanting to do some screening for ACEs. And of course, it's always a challenge, but particularly for adolescents. One of the things that a lot of adolescent care providers are saying to their parents is once your child reaches 12 or 13 or whatever they think the magic age ought to be, I will be talking to them by themselves. You don't like that, you better find a different pediatrician. They don't go there, but that's the rules of their office. And then they do asking about ACEs when the mom isn't there. There are also challenges with that approach in terms of consent, in terms of the electronic medical record being available to parents, which many parents think they ought to have all of it. It's where do you chart some of these very sensitive issues? Is there a part of the electronic medical record that you talk to the patient about keeping in a separate place that's not available to whoever they said could look at all of their charts? One of the things for abused women is that, when they first start up in this relationship, they say, sure, yeah, you ought to have access to my electronic medical record, like you have access to all my pins and my, all of everything. And then when it starts to become abusive, then they're like, so how do I say, oops, I'm going to take that back. I'm going to change all of my pins. And when you try and get in there, you're not going to be, is that going to make him mad, et cetera. So there are challenges with that. People are working on it, and there's a number of folks that are, Megan Bear-Merritt, who's a pediatrician at Brigham and Women's, has done a lot of good work on some of those issues. So no easy answers, many challenges, but it's something that we need to think about. Yes, ma'am.
Did officer gender?
Because she's a woman.
Yeah.
Yeah.
Impact the outcome of the lethality?
Yeah, on hindsight, data we should have gotten. Were we smart enough? No. And seeing that, it makes me wonder. We know we did some validity checks in terms of whether or not the officers really did what they were supposed to, et cetera, and so forth. I'm sure some of them did it badly. It's just like our health care providers. I'm sure some of them did it badly. We find we need to go back in on these LAP places and do booster kinds of training, especially for new officers, et cetera. And it's been developed with a roll call training, so it's very, very short. So yeah, there's challenges with that, and I would love to know the answer to that. Good question. Yes, ma'am.
Thank you, Dr. Campbell, for your presentation. My name's April. I'm a PhD nursing student. My question is for the statistic that was listed in terms of, do you have perception on the barriers to the lethality scale being used by more police departments? And since it's scripted, has it ever been considered to be used in healthcare systems so that when providers are asking, they have more of a standard way of asking the question?
I'll answer the first question last. So the LAP is being used in some emergency departments. There's also a short form of the danger assessment, which is even shorter. It's 5 questions in the LAP that we have worked on and validated, particularly for healthcare providers. And that's on the danger assessment website. Your first question, so I liked it.
I actually read a short article that at the time the statistics were given a few years ago that only 35 police departments were using it across.
Right. Yeah.
And so I was just wondering what the barriers are.
Well, the barriers are will. Some police chief has to say, you're going to do this. After the study, interesting, the Oklahoma State Legislature passed a law that all of the jurisdictions are going to use it. Now, you always wonder about these mandates and are they going to do it really badly because they were made to do it, all of that. But, that's a thought. So you have to have the will of the police department, and before they do the LAP, they have to meet with the local domestic violence organization. So they have to coordinate their efforts because it is not just them, It's getting her in touch with the local domestic violence organization. So that's one of the rules. And the Maryland Network Against Domestic Violence are those that provide the training for police departments. Jay Sargent is a retired police officer, so it's police training police. And they are funded by the Department of Justice through the Office of Violence Against Women, and they're a technical assistance center. And so police departments can apply to them to get the training on the LAP. So that's one of the barriers. Somebody has to make that application. So there has to be the will available. But family justice centers, don't you guys have a family justice center? Did I make that up? I wished it for you. Pilot. Okay. Yeah, and some of the family justice centers are doing a version of the LAP through there. Yes, ma'am.
The Birmingham Police Department, West Precinct is doing the pilot project, and we're now starting to work with the Safe House in Shelby County to cover Hoover because we both cover 6 in the area.
Awesome. So, watch for it coming here, and that's something, again, if you offer to call the police for her, hopefully you can get tagged into the LAP. One more.
So I know that there's intervention when you're
Yeah, right, right. And many men who are incarcerated are also domestic violence offenders, even if they're not being incarcerated for that crime. Okay? Yes, that's happening in a few places. The Oliver Williams would be a good person to contact in terms of his prisoner reentry program, because it has a fatherhood component as well as a, don't hit your wife. Not that it's that easy. But it's very much trauma-informed, which is necessary. So that's a good one. There's a few other places that are doing that. Again, it takes resources. It takes community will to put that into place. But there are some good ones. And that's IDVAC, the Institute on Domestic Violence in the African American Community. IDVAC. Well, there you go. We got a member right here. So she can get you in touch with Oliver.
I think we could probably continue this till noon. But Jackie,
There's a reception. That's
there is. But there is, first of all, Jackie's passion for knowledge, for science, has been so informative, and I think has also given you all some tools to be armed with. And when I think about the 3 million nurses in this country, and then almost 20 million nurses in the world, nurses are everywhere in communities, and my goal, and I think our goal, should be not to even have to use the tool of the policeman, to be able to recognize this, to prevent it from ever getting to that point. And that's probably not totally realistic, but we could stop it if we recognized it and took the time to ask. So thank you so much. But we have a little something. This is just a small token, and you don't have to open it. We will even send it to you, so you don't have to take it to California. But just so you know, it's just something that is recognizes Jackie and gives her our appreciation for inspiring us as nurse scholars and leaders today. So thank you very much.